Good morning, everyone, and a very warm welcome to the session Physical Therapy Leadership in Disability and HIV, Sharing International Perspectives. My name is Stephanie Nixon. I'm an assistant professor in the Department of Physical Therapy at the University of Toronto in Canada. I'm also a research associate at a university in South Africa at the Health Economics and HIV/AIDS Research Division. And I am very happy to be here with you early in the day to address an extremely important topic. We are so excited to be hosting this symposium today because we think that this is going to be a symposium to remember, that this symposium marks a very significant shift in the field of HIV rehabilitation and disability. We think that this symposium addresses an idea whose time has come. For a long time, it's been the same few people who have been talking to each other about HIV and rehabilitation and disability. And we've been talking conceptually. We've been talking about the potential for rehabilitation to support and meet the needs of people living with HIV. We've been talking conceptually about how HIV affects many body systems, has all kinds of related diagnoses, has all kinds of side effects from treatments that create challenges for people over the course of the day and the week and the month and the year, which physiotherapists and others in rehabilitation are well positioned to address. But most of the time, it's been conceptual, and it's been we should do things, and it's been about advocacy for stepping up and meeting the challenge. Well, what we're proposing in this symposium today is that we are now beyond that phase, and that there are real, tried and true, incredible innovations happening around the world in which physiotherapists are attending to the needs of people and communities living with HIV. And that's the focus of this symposium. So here are our two objectives. Ambitious, perhaps, but why not? We'd like to launch a wave of innovative thinking about physiotherapy and HIV, and we'd like to plant the seeds of a community of practice. I have a feeling that it's not the same few people that are just talking to each other about this issue anymore, that there are many more. Some are in this room. Hopefully we'll talk all of you in this room into being part of this way of thinking, but that it extends well beyond this room, that this is one of those fields that's beyond the same people that know each other. And so how we hope to do this today is a format that's also a bit innovative. We are not going to have speaker after speaker giving you long presentations about research. We're going to shake it up a little bit. Instead, we are going to give you quite concise presentations about specific innovations. In fact, we're going to present 6 innovations that are happening around the world today. And if you want more information, because they're only going to be about 5 or 6 minute presentations to give you just a flavor of what these innovations are about. And if you want more information, we're going to give you an opportunity to get more information. But hopefully we're going to whet your appetite by talking about the innovations. We're going to give you a chance, briefly, periodically, to reflect on what this might mean for you in your clinical practice, in your research, in your advocacy, in your way of seeing how you do your work. We have reserved time, lots of time, at the end of this session to not only speak at you, but to speak with you. So for those of you who feel so inspired to share with us some of your innovations in HIV and physiotherapy, whether they are actual or new ideas that you've had through this session, there's a portion of this symposium devoted to that. And finally, we're going to develop a symposium report. It's going to include all the slides that you see today. It's going to include an overview of the discussion that we have. And if you want, it will include your name and email if you're okay with that being shared. If not, we're happy to just blind CC you on the report. And my colleague Kelly is going to send around a sign-up sheet. On that sheet, it'll ask you if you'd like to receive the report from this symposium by email, for your name, affiliation, your email address, and if you're okay with your name being shared. So if you'd like to be more public in that community of practice, this is a report that will only go to people who sign up on that list. But if you prefer for it to be private, that's no problem. You can let us know. So that's the plan for this morning. And so without further ado, we are going to start with two innovations. One is a mentorship program, and one is an online course. Julie Hard is going to tell us about both of them. And Julie earned her master's degree in physiotherapy at McMaster University in Canada. She worked at the Canadian Working Group on HIV and Rehabilitation as the mentorship and curriculum coordinator during much of this work, as the chair of the International Health Division of the Canadian Physiotherapy Association, and as founder of the Kenya Working Group of the International Centre for Disability and Rehabilitation at the University of Toronto. Her interest in HIV care has extended beyond Canadian borders. Julie has been awarded the International Health Award by the Canadian Physiotherapy Association for her involvement in global initiatives, and she is currently the country director in Haiti for CBM. Julie.
Thank you. So, as Stephanie had mentioned, I'll be looking at two innovations that I was privileged to be part of. That was through my work with the Canadian Working Group on HIV and Rehabilitation. And the first project was basically looking at a mentorship program, the HIV Interprofessional Mentorship Program for Rehab Professionals. This mentorship project started off with a pilot phase. We presented a model for interprofessional mentorship in HIV and rehabilitation. And since the model, and which I'm going to actually describe the model, we've had two subsequent mentorship programs that have been structured and that we've run within one region in Canada to provide HIV information, but more importantly, to allow that information to be applied in better knowledge translation and practice, and to motivate clinicians not necessarily working in the area to understand a little bit more about how they can respond to the capacity and build their capacity in responding to the needs of persons living with HIV. Okay. So the innovation. Essentially, it was a 6-month mentorship program for rehabilitation professionals to learn a little bit more about HIV and the issues that affect people with HIV. The mentorship project was an interprofessional panel, including people living with HIV as experts in the area of HIV mentorship, as well as sharing with the mentees their lived experience. There was a formal structured component to the mentorship program, and there was also an informal component to the program, and it was based on case-based learning from clinical practice. Ultimately, the clinicians were linked together, and the persons living with HIV mentors were linked through an online forum for ongoing discussions and resource sharing. So our mentors. Our approach was to bring together mentors from, in our pilot phase, clinicians with expertise in specialty teams working in an urban center for HIV care. These professionals came from the area of physiotherapy, occupational therapy, and speech-language pathology, as well as 3 people who were long-term survivors living with HIV, who had lived experience but could also promote client-centered practice and would be able to contextualize the challenges faced by persons living with HIV. We also had mentees who were recruited from a general call through the professional associations in OT and PT and SLP within the region. And essentially, the call brought together the mentees who, in the pilot phase, were all physiotherapists. Panel mentorship is important, and it's a bit different than the traditional model of mentorship because it breaks from the one-to-one relationship, and it allowed the mentees to capitalize on the skills of many experts through team building, through mutual competency, and experts could share not only with one learner, but with the group of mentees themselves. The program started with a launch. Basically, it was a one-day workshop where resources were provided in the form of a workbook, relevant articles, and written materials were given about HIV and rehab. And it also provided an introduction to HIV as a common understanding and provided some baseline information within the context of HIV. And that day allowed for the mentees and the mentors to set normative rules on how they would work together and communicate. The structured component allowed for 5 subsequent teleconferences, and the agenda was based on problem-based learning for about 1.5 hours once a month. Problem-based learning is basically providing clinical problems, information about clinical problems that the mentees were having within their practice. And when somebody was completely new to HIV, the mentors themselves would share cases, or the persons with HIV would share experiences so that they could have a common dialogue and make it relevant to practice. Between the sessions, a logbook was asked of all of the mentees to be kept, and a journal, and we encouraged people to contact one another and to identify their learning needs and who amongst the panel would be appropriate for them to have their needs met. Ultimately, why is this innovative? Because mentors formed a panel. It broke from the traditional one-to-one mentorship program and allowed people to access the expertise in a limited number of people who shared or who had that expertise, that they were able to share it more broadly. We adapted the program as well, and so it's innovative because after the pilot, we continued to innovate, and we switched from a teleconference to a video conference, which allowed us to bring people together from very far regions as opposed to working in one urban setting. We had the urban expertise shared with rural areas that were not necessarily able to access those resources. We increased the number of mentees, and we increased the number of mentors as well to include nutrition and social work. And we increased the network of participants, so each mentorship group was able to feed into a network that they could access the resources. This allowed us to bridge geographical distances and to increase the capacity of care for persons with HIV. The second innovation I'm going to talk about is an online course specific to rehab professionals interested in HIV care. This course was adapted from an in-person interprofessional course that was hosted in a number of sites across Canada that was in a workshop form. But it's very difficult, given the constraints of geography and finances, to be able to widely disseminate and provide the information that was available within the course. And that was the motivation behind why we developed this. The online course is specific to rehab professionals interested in the care of persons living with HIV. There's a lot of material about HIV itself, but this consolidates and brings together rehabilitation-specific information through 7 modules. The modules range from about 20 to 45 minutes to complete, and each module is guided by a clinician with extensive knowledge in the topic area. So this learning tool has been piloted in 3 university rehab programs within Canada. And it's a great resource because the learner can go back to the information at any point in time. It provides clinical information and condition-specific information so that at a later date, if a patient does come into clinic, that you can refer back to the pathology and make it more relevant to the situation that you may be encountering. Essentially, you can also look at the rehab roles and interventions not only of physiotherapy, but other professions working in HIV care. And this screenshot basically shows information related to physical exercise as physiotherapists, and it's also evidence-based. So we try to provide resources and information that can help guide the learner back to the evidence-based practice. The learner can also see at the bottom of the screen there is a sliding bar which tells you where you are progressing through the course. And it also allows people to link with one another if you have a specific question. I've highlighted in blue at the bottom where you can enter the question and your email, and that goes into the network to allow people to respond to and provide more information, or to receive more information from clinicians working in the area. So it's not a course that's done in a vacuum, but you can come to it at any point in time and basically receive information. And as I said, the last module in the course brings you to a case study where you'll have the opportunity to look at different patient or case scenarios, patients' charts. There are 4 case studies that are currently loaded which reflect different areas of practice, different challenges a person with HIV may be encountering, and allows the clinician to essentially work through the case and try and problem solve and figure out resources, how they would address the situation. And it says, in this case of Sonia, there's a quiz associated. It's not really a quiz. It's asking you to apply the knowledge that you've had into a question-based format so you can challenge yourself. Okay, why is this innovated? Because it's accessible to all rehab professionals with internet connection, which makes it more broadly disseminated and reachable to people all around the world. The content is specific to rehab professionals, and it, again, builds on an interprofessional approach. The learning modules build one on top of the other, but we can also add learning modules, for example, in the area of aging in HIV, as new information is becoming available, or mental health in HIV. These are potential modules that we're looking at in the future. And it's a very interactive and engaged learning way of processing information to make it enjoyable to sit in front of the computer for a period of time and to go through the material. If you have any questions or you'd like information on either of these two, I've provided the information here. And I think at this point in time, I'm going to just remain at the podium, and if there are any questions or points of clarification, I'd be happy to entertain those.
So any questions for Julie?
Hi, my name is Mafalda. I'm from Portugal. I'm still a student. I'm in 3rd year, and I would like to know if that program is open to everyone, because I'm still a student. I don't know what area I'm working to when I go out to the professional market, so I'd like to know more, please.
Certainly. I've provided the website and the information up on the screen here because it is an online course. It's offered in both French and English, and so if you were to email the person on the screen, then you'd be able to access, basically you'd be given a username and password, and you'd have to discuss entry. So it's not a course that starts at one specific point in time. At any point in time, a user can access the course and be able to begin. Yeah.
Okay, that's very interesting. Thank you.
Welcome.
Any other questions for Julie? As you know, HIV disproportionately affects Southern Africa. One of the leaders in HIV and rehabilitation broadly in Southern Africa is our next presenter. Hellen Myezwa is the head of department in the Department of Physical Therapy at the University of Witwatersrand in Johannesburg. She completed her PhD with a focus on mainstreaming HIV into physiotherapy education. She's currently involved in supervising postgraduate students in HIV research and reviewing HIV input into physiotherapy curricula, among many, many other achievements. Hellen previously worked in community-based rehabilitation for 15 years. Hellen.
I'm always frightened by such introductions. Thank you very much, everybody. I was a bit worried in the beginning. I thought I'd be talking to the chairs, but I'm glad you are all here, and thank you for coming. I chose only to speak of one innovation because I'm passionate about understanding what really happens because of the impact of HIV on many of the patients that we interface with. I'd like to recognize two of my co-authors on this paper who are in this room. I see Professor Stewart over there, Amy, and I see Professor Yalsma Jenny over there, who worked with me. This is actually coming from a paper that has just recently been published in Physiotherapy. And the innovation, we chose, as you can see, to approach our presentations by saying what is the innovation that each of us is sharing with you today. And my contribution to this is that we've been using the ICF both in Southern Africa and in Canada to frame the problems that are presented by people with HIV. And I wanted to test some of the what is claimed to be one of the major uses of the ICF. And I got 4 data sets and compared the set of ICF codes for people living with HIV. And the idea was to evaluate the implications of the codes presented on the roles of therapists on service delivery. And to further the innovation, it provides an understanding of HIV in differing contexts, both in South Africa and Brazil. And it also uses and compares 4 HIV-related data sets in different contexts and tests the feasibility of using the common ICF language. A little bit of detail for you of what the 4 studies were. In the South African study, the first one was a small study which was done in Cape Town. It used the ICF checklist. As you can see there, that is what it used. I'm testing this. Yes, here we go. It used the ICF checklist, and most of the people who were assessed were in stage 2 and 3, the WHO staging of HIV. In South Africa, the second and third study, which is this one here, used 2 separate groups of patients. One group was inpatients in a hospital. The second groups were outpatients in a government hospital. And they were in across the 4 stages of the WHO staging. Some of them were on ARVs and some were not. And we also used the ICF checklist. The 4th study was slightly different. It consisted of 42 patients, and they were post-long-term, on antiretrovirals and long-term, and had been on treatment for quite a while. And they used a modified core set developed after examining the literature through a systematic review. But essentially, they used a lot of the same codes from the ICF checklist as we had used. So I just, very briefly, I didn't share too many of the results, but to give you a little taster of the kind of results that we could compare, I chose among impairments on the mental functions, for example, energy and drive as the blue, and sleep functions, which was the green, memory, the light gray, and emotional, the white. And these are some of the impairments that were problematic, and you can see the differences. The inpatient group, not surprisingly, had the most problems because these are people who are in episodic illness, whereas the Brazilian group, there were people who were being on long-term treatment, are at work, and really did not experience as many problems in certain of the codes. And of course, the mining group, which were people also in employment, had problems, but they were less so than the other areas. Another example of some of the results that we saw, the domestic life category, acquisition of goods, for example, was more problematic for the 2 South African groups that I studied, and less so for the other 2 groups. Preparation of meals, the same thing, and housework, and whereas the Brazilian group had absolutely no problems at all. A third area that I wanted to share with you was in terms of use of services and systems and the policies that the patient group would normally interface with. Again, you can see that everybody experienced problems, but more so in the group that was perhaps more functional than the other 3 groups put together, which was the Brazilian group. So what are the next steps, and what does this mean for us? It really shows that the ICF is useful in framing HIV for the comparison of data across the different cultures and contexts. The results help us as therapists to understand our own role within the episodic disease continuum, because you can see that of the 4 groups, there were those that were actively in an episodic illness and others who were not, essentially ill, but still experienced problems for which there would be need for intervention. And another possibility that could come out of this is that a number of core sets collected under the ICF and relevant to the different stages is a possibility, as opposed to considering a core set that is only applicable to HIV overall. Another important thing that could come out of this is to define better the points of intervention and use the results to implement intervention studies that test the effectiveness of some very simple interventions. So I thought a way to end my sharing with you is to look at possible interventions that are innovations that are already happening, and the direction that perhaps as therapists we need to think about in terms of HIV. At the moment, work in understanding the use of ICF and illuminating deeper problems amongst people with HIV is underway, and our university and department is collaborating with the HIV Economic and Research Development and the University of Toronto, and hence my collaboration with my colleagues here, Stephanie and the others. And then the second thing that has been happening, and here I'm kind of reporting, is that there's already a lot of efforts towards the use of results to implement intervention studies and to test the effectiveness of simple interventions. Some of the literature, if you're familiar with it, out of our university have come to one major study which tested exercise, and I don't know if Eugene is here, Eugene Mutamura, who was supervised by AME, and he looked at the impact of exercise on HIV, specifically looking at redistribution of the body fat in lipodystrophy. Currently, there are 2 students who are looking at simple interventions at community level, looking at the risk of ischemic heart disease and looking at the impact of exercise on peripheral neuropathy. And one of our colleagues, David, I don't know if he's here as well, he's from Rwanda but working with us and under Professor Stewart. A third innovation that we're looking to work towards is assessing the sensibility of the HIV disability questionnaire, which has been developed by my colleague Kelly and Steph, and we want to see if this is suitable for a South African sample. So in essence, we're looking at really collaborating to bring together efforts of a few people, but showing the importance of collaboration in order to get things moving forward. And I think I wouldn't be correct not to make a special mention of the pediatric arm of our research. My colleague unfortunately had to go somewhere else today. And there is research and there have been previous studies on the effects of a home stimulation program on infants who are infected with HIV. And my colleague and her team have taken this forward to look at the current effect of HIV using the Griffiths tool on preschool children between the ages of 3 and 5, and looking again at the impact of a home stimulation program. I only mentioned these few, but that's not all that is going on, and I'm sure that my colleagues in our continued discussions will add to this. Thank you very much.
Are there any questions for Hellen? You were crystal clear.
Thank you.
In the history of HIV, there are several countries that have shown extraordinary leadership, and Brazil is one of them. Historically, you can look back over time and see incredible political and scientific leadership out of Brazil. And the same is true around physiotherapy and HIV. I am delighted to introduce Gabriela Abbud, who's also joined today by her colleagues Cristina Sá and Raquel Carvalho. Gabriela received her BSc in physiotherapy in 2005 from the University of Sao Paulo in Brazil, and her MSc in exercise science in 2008 from Concordia University. Her first contact with physiotherapy practice in the area of HIV and AIDS occurred during an internship in Brazil with the Infirmary of Infectious Contagious Diseases. And I will note that this is one of those fields where students and new grads are often leading the way. There are many dimensions of our work where the more senior you are in a profession, the more experience you have, and you've seen it over time. This is one of those fields that in many cases is so new that it's the younger people in the profession that are leading the way. There's room for everyone to be a leader within the field of HIV and physiotherapy, and Gabriela is an excellent example of one of the younger leaders. Gabriela is currently working as a physiotherapist at the Centre de Réadaptation Lucie Bruneau in Montreal, Canada, and at the Montreal Chest Institute. Gabriela.
Good morning, everyone. It's a pleasure to be here today to present the study that we've done in physiotherapy evaluation and intervention of children born to HIV-positive mother. As Stephanie mentioned, I'm joined here by my colleagues Cristina Sá and Raquel Carvalho, and they deserve a lot of credit for this project because they are running that in Brazil with the support of the Federal University of São Paulo in the city of Santos. So what is this innovation? As I mentioned, is a study to evaluate the neuropsychomotor development of children from 0 to 12 years old born to HIV-positive mother. But based on this evaluation, to orient parents and provide physiotherapy intervention if a delay is observed. But most of all, this project is to support the role of the physiotherapist in the multidisciplinary team. Why is this an innovative project? Just to give you a little bit of background, in 1986, a Department for STD and AIDS was created in Brazil by the Minister of Health. And one of the initiatives was the creation of the Referral Center for AIDS, the CRAIDS. And the scenic portion is the pediatric portion of the CRAIDS. These referral centers are composed by a multidisciplinary team, a doctor, a nurse, a social worker, a nutritionist, and a psychologist, but not a physiotherapist. This is particularly important in the city of Santos that has interest in HIV epidemiology. Santos is the city in Brazil with the highest prevalence of HIV. And why is that? Well, due to the characteristics of the city. It's a port city, a tourist destination with a high number of sex workers and drug users. However, due to the efforts from the CRAIDS, since 2008, there is near 0% of vertical transmission in the city of Santos. But we don't know what is happening with those kids, what is their development, because there's no physiotherapy follow-up of them. So what we did, we followed those kids from 0 to 12 years old to identify what are their motor development. And from 0 to 18 months old, we used the Alberta Infant Motor Scale And what you can see here are the results plotted in the graph. The blue dots represent kids that are above the 5th percentile, and the red dots represent kids that are below the 5th percentile in their development. Those dots here, they are highlighted in red, are kids that are way below the expected percentile. So those two kids, their parents were oriented and they were referred to the physiotherapy clinic affiliated to the university for stimulation. But what we see is that 50% of the sample is above the 50th percentile and 50% is below. So this sample is representative of the population, but also is telling us that they are following the general pattern. So from 2 to 7 years old, all those kids are HIV positive, because what happens is that they are followed until the age of 2. And if by 2 years old they are not HIV positive, they are discharged from the crates. But if they are followed up until the age of 12 in the SNIC branch, which is the pediatric branch, and after that they are referred to the adult clinic. So we evaluated those kids by the Denver Development Screening Test, which is a test that measures fine and gross motor skills, language, and social skills. And all those kids, the 5 kids that we evaluated, had normal development. From 3 to 7 years old, we used the progressive neurological examination, which attests the dynamic and static balance as well as functional coordination. And all those kids had a decrease in the dynamic balance. This decrease in dynamic balance is mostly driven by a reduction in muscle strength and endurance, but not necessarily a delayed development. The group from 8 to 12 years old, we can identify 2 subgroups. One that is on the left side, HIV-positive kids. They were evaluated by the Pediatric Balance Scale, which is a modified version of the Berg Balance Scale. And their score ranged from 53 to 55. And what is happening again with those kids? Why are their scores reduced? Basically due to a decrease in the score for the forward reaching test. The other group, which are the kids that have AIDS, they were evaluated by the same scale, and their score ranged from 27 to 52. So what's happening here in this group, all those 3 kids have neurological sequelae from their disease. And why this is happening? Well, the 3 mothers of those kids did not follow the treatment due to several reasons, but they did not follow the treatment. So where are we going from here? So we want to continue with this longitudinal study to identify and treat kids with neuropsychomotor delay, as Hellen was saying, to provide stimulation for the kids that are in need. But also to identify HIV-positive children at risk of presenting motor impairments. So when their kids are old, what is happening with their motor abilities and how it's impacting their life in their school participation, for example. But also, and most importantly, to demonstrate the importance of the physiotherapist in the multidisciplinary team at CRAIDS for the pediatrics branch. And to show that physiotherapy is important to evaluate those kids, but also to prevent further impairments. Thank you.
Are there any questions for Gabriela?
Thank you very much. Very interesting presentation, and of course a problem that we're going to be facing more and more as children survive longer and longer. I'd just like to know what the HIV, the ARV protocol would be. Are the children put onto antiretrovirals as soon as they were identified, or what would be the protocol that these children would have undergone in terms of treatment?
Well, the protocol that is followed is the recommendation of the World Health Organization. So when the mother is followed with the antiretroviral treatment before, the kids, when they are born, they receive the treatment, the medication by like a syrup, and they are evaluated. Their viral load is evaluated by 2 months old. Correct me if I'm after 1 year and 6 months, and then at 2 years old. And if they're not HIV positive by 2 years old, means that they will not be, so they are discharged. So it's the World Health Organization protocol. Did I answer your question?
Now, I want to know what the antiretroviral therapy, do they start immediately they're diagnosed, or do they wait for their viral load to drop, or is it in terms of when they have opportunistic infections?
For the kids?
Yes.
When they are born.
So they start right from the
They
beginning.
start right when the kids are born, yes.
Any other questions? We're going to finish off our parade of innovations with two more. And these are big ones. These are big, exciting innovations that are going to be brought to you today by Kelly O'Brien. Kelly is a physiotherapist and a researcher. She completed her PhD in clinical epidemiology at the Graduate Department of Health Policy Management and Evaluation at the University of Toronto. She's currently undergoing postdoctoral research with Professor Patty Solomon at McMaster University in Canada. She's a lecturer in the Department of Physical Therapy at the University of Toronto and a board member of the Canadian Working Group on HIV and Rehabilitation. Her doctoral work included developing a conceptual framework of episodic disability from the perspective of adults living with HIV. Kelly.
Thank you very much for being here. I have the pleasure, as Steph mentioned, of presenting on two innovations. The first is something called the HIV Disability Questionnaire, and this has been a focus of a lot of my postdoctoral work at McMaster University with Patty Solomon, who is here today. The purpose of this questionnaire, and it sort of arrived from some earlier work done with respect to looking at the experiences of disability from the perspective of men and women living with HIV, and finding that the existing measures out there, many of them health-related quality of life measures, didn't really capture the concept of disability that was experienced by this population. Questionnaires seem to do a pretty good job at capturing symptoms, difficulties with functional activities, but not so great at capturing issues related to social inclusion and the uncertainty or worrying about one's future living with HIV. So hence developed a need to develop a new HIV-specific disability questionnaire. This is called the HIV Disability Questionnaire, or HDQ for short. Its purpose is to describe the presence, severity, and the episodic nature of disability experienced by adults living with HIV. The HDQ was developed based on a qualitative phase of research done with 38 men and women living with HIV, and also developed in collaboration not only with researchers but with a community advisory panel that's been working for a number of years now on bringing this HDQ to fruition. It is now was developed with men and women specifically living in two cities in Ontario and Canada. And the characteristics of this questionnaire, it consists of 72 items that span 4 domains or dimensions of disability, and has one final item that asks individuals whether or not they're completing this questionnaire on what they would consider being a good day living with HIV or a bad day living with HIV, trying to get a sense of where individuals are within that episodic continuum at the point of time that they complete the HDQ. This is a self-reported questionnaire that asks an individual how they are feeling on that given point in time of day. There are 4 domains here of disability, and you can see the number of items that are allocated to each domain. This is an example question, so asks individuals how they're doing on that given day, and individuals are asked to complete a 7-point Likert ordinal response scale. And then for every health-related challenge, individuals are asked whether that challenge has fluctuated, either improved, worsened, or both over the past week. And this is to try to capture the daily episodic nature of disability that might be experienced. The questionnaire takes on average about 11 minutes to complete. There are 4 domain scores, an overall total score, and as well as an episodic score. Higher scores represent a higher prevalence, severity, and episodic nature of disability. So the HDQ is innovative because it's the first known HIV-specific measure of disability. It's based on this episodic disability framework, which was a conceptual framework that was derived from the perspective of 38 men and women living with HIV. And some details around this framework have been published and are openly accessible via these links here. This framework and the HDQ are innovative because it was derived specifically from the perspective of people living with HIV. It tries to capture this episodic nature of disability and includes the uncertainty or worrying about one's future as a key component. This next slide demonstrates an example of what one's experience living with HIV-related disability might look like with respect to the episodic disability framework, characterized by periods of both wellness and illness. But this disability may be influenced by extrinsic or environmental, as well as intrinsic or personal factors as well, that could either exacerbate or alleviate different dimensions of disability across the continuum. And these episodes of disability may be triggered by life events, such as receiving one's diagnosis or experiencing an opportunistic infection that may result in hospitalization. Some of the next steps with respect to the HDQ, we've just completed collecting data on 360 men and women living with HIV, and we're going to be looking at evaluating the domain structure of the questionnaire and its internal consistency reliability. Next stage, we're going to look at retest reliability and construct validity, administering the HDQ at 2 times, week 1 and then week 2 apart. So everyone involved in this work is now finding out the amount of time and energy that it takes to develop and also assess the measurement properties of the questionnaire, but we're getting there. And future research will involve looking at the interpretability. So what do the scores on the HDQ really mean? And how well is the HDQ at identifying change in disability when change actually occurs? And lastly, as Hellen mentioned earlier, this HDQ has been developed within the Canadian context, so it would be very interesting to look at the measurement properties for use with adults living with HIV in South African and other HIV high prevalence contexts as well. The next innovation that I'm going to speak to is on behalf of the Canadian Working Group on HIV and Rehabilitation, or QWIGR for short. QWIGR is a national working group that was formed in 1998 that works to address the traditional fields of traditional being originally siloed of HIV, disability, and rehabilitation, and bridging those through cross-sector partnerships that span research, education, practice, and policy. The e-module for evidence-informed HIV rehabilitation is a comprehensive 223-page electronic resource or document developed to increase the knowledge and skills of rehabilitation professionals in working with HIV care. It was updated based on a previous Module 7 that was developed back in 1998 specific to rehabilitation professionals and was funded by HealthForce Ontario Interprofessional Care Education Fund. This e-module is also based on some of the work that Julie originally presented from QWIGR on their online course and their mentorship course. So they've really been driving something called QWIGR Campus and putting together a number of different educational resources on HIV care for rehabilitation professionals. This e-module is openly accessible to anyone. You can go to the website here and click on the link to access the e-module. It is currently published in English, and it is in the process of being translated into French as well. This e-module is innovative because it's the first comprehensive resource specific for rehab professionals, so occupational therapists, physiotherapists, speech-language pathologists, and physiatrists. It incorporates best evidence and is based on a comprehensive literature review. And it was really interdisciplinary in its approach to development. So QWIGR collaborated with a large team of authors, editors, and external reviewers, including people living with HIV, clinicians, researchers, and advocates who are involved in authoring a number of different chapters. But some of the notable sections to highlight here is there is a chapter specifically on aging and concurrent health conditions living with HIV, cognitive rehabilitation, There are specific chapters on evidence-informed rehabilitation interventions and specific information and practical information on how to access rehabilitation and issues surrounding advocacy. One of the gems of this e-module is that the very last chapter, Chapter 8, includes 6 comprehensive case studies. And these allow an opportunity to practically apply the knowledge and skills developed throughout the course of the module. Each of the cases has guiding questions to promote critical thinking among rehab professionals or students about assessment, analysis, and treatment interventions. And these case studies can be tackled either independently or as a group. There are discussion notes that are embedded with links that bring you back to specific chapters within the module that base on a given topic at a particular point in time in the case. So these are a really great resource and learning tool with respect to HIV and rehabilitation. Some of the next steps for this e-module, it is a working document, so there will be periodic updates made to the e-module to ensure that the content includes current best evidence. And we're also involved in a phase of research in looking at how well this e-module, the nature and extent to which it's taken up by rehabilitation professionals. It's just been launched within the past month. So now we're interested in finding out how is this e-module being used by rehabilitation professionals, what are some of the barriers and facilitators to its use, and we're also going to be looking at how we can modify this e-module specifically for people living with HIV to use it. And this is a 2-year project, so I'd be interested in talking to anyone who might be interested in learning more about this particular project. And there's my contact information there, so I'm happy to take any questions.
Any questions for Kelly? Kelly, I have one. Can you explain how this is the same or different from the online course that Julie introduced earlier?
Yeah, it's a good question. So this is, Quigger has a menu of educational tools and resources out there. The mentorship program being one, the online course that Julie presented as being one, and this e-module as well. And it's all a part of something that Quigger's called Quigger Campus. The e-module that I just spoke about is openly accessible to everyone via that link. The online course that Julie spoke to earlier, there is a cost associated with the online course, and Quigger is still working out the details on the pricing of that course, which there will be different costs for example, a student to take it as an individual versus a university who might want to purchase a license for using it with an entire class, for example. So there are some slight differences there, but there are still the case study similarities that span and the content areas as well.
My name is Margaret from Stellenbosch University. Thank you all for the innovations and for the presentations that you've given this morning. I wanted to know if any one of you responded to the WHO call recently for innovation or best practice HIV and disability work.
Can you tell us more about it?
Yeah.
I think they're looking for, there's a lot that has been written on disability and HIV, but nothing in practice. So if they want to recommend to disability organizations how to intervene, how to involve people with disabilities in HIV prevention, treatment, and care. So they're looking for best practice. And I think what you have presented is best practice in different aspects. The only thing is that maybe disability is not mentioned in the context of maybe someone with a visual impairment who becomes HIV positive, or someone with a physical disability who becomes HIV positive. So the question is it possible for your different innovations to focus on that particular aspect of disability and HIV?
Mm-hmm. Yeah, very good question, and I think you've touched upon some of the work that Stephanie, who, although she's facilitated this session, hasn't spoke about some of her specific innovations, who is doing specific work on people living with pre-existing disabilities. who are also now living with HIV. So,
Quite right. So, an innovation that I'm up to these days is a study that's based in Zambia that takes as its starting point people with disabilities and their systematic exclusion from HIV policy, practices, and programming through the history of the pandemic, actually, until about 5 years ago. Again, leadership out of the South by disability organizations and communities themselves saying HIV is affecting us, it's affecting our caregivers. In the last 5 years, there's been quite a bit of literature starting to emerge around prevention and vulnerability issues related to people with disabilities. What's missing in the literature is anything that addresses the treatment, care, and support side for people with disabilities who have become HIV positive. So, if you are so inclined, from 12 to 1, Hall 2, I have a poster on what we're calling the SEPO study. It's a Lozi word, Zambian word for hope. This is a study in Zambia with people with disabilities who have become HIV positive and their perspectives on health equity and other life experiences of living with HIV. So if you're interested in this disability movement, if you're interested in intersectionality, that's what we're tackling in that presentation. Helen, did you have anything you wanted to add? Thank you. You hit the button.
Okay. Yes, I wanted to say that, yes, there is work going on. It's probably not pioneered by the physiotherapy movement. It's much more multidisciplinary. And I would like to mention our colleague Jill, who we're working with. She's a psychologist who's working at Herd, and her focus is on people with disability who have become HIV positive. So there's a lot of linkage. But the call out by WHO was fairly recent, Mary. Where are you? Oh, this was fairly recent. And I think that even the inclusion of HIV in, ministry policies has only just come out in the last 18 months.
We did a study on children with disability, looking at their sexual behaviors in just in the Cape Flats, just because I'm from UCT. And we found a lot of very risky behaviors going on with children with disabilities. So one must remember that it's got to start right at the beginning in terms of educating the children. And some of them, of course, had been abused. Some of them actually had abused other children. So just because they're children with disabilities doesn't mean to say that they're not, sexually active and not open to all the same sort of sexual risks of transmission. Thanks.
So way back at the beginning of this symposium, I identified two objectives. The first was to launch a wave of innovative thinking about physiotherapy and HIV. And the second was to plant the seeds of a community of practice. And one of the ways in which we wish to do that is by the sharing of a report of this symposium. Now, Margaret, I'm going to talk to you to find out the details about that WHO call, which we will put into the report as well. But here we are in the home stretch, because I am certain that it's not just us that have innovations. And so I have a new question for you. Think for yourself. What is an innovation in HIV and physiotherapy taking place in your context, or that you could imagine for the future? So it may be happening now, or it may be something that you could imagine in your future. But I want you to think of one innovation in your context. And we want to hear about these innovations. Getting up in front of 75 people isn't for everyone, but it's for some of you. And some of you have important innovations to share with us. So this is the time we would like to invite you to step up to the mic, tell us who you are, and tell us about an idea you have for an innovation either currently taking place or for the future. And this is also going to be collected in the report that we share. So my profound gratitude to the man standing at microphone 2.
Okay, thank you very much. I'm Bukhtiyar, came from Bangladesh, and my identity is I'm the Secretary General of Bangladesh Physiotherapy Association.
The Secretary General of?
Bangladesh Physiotherapy Association.
Yep.
And I'm working in Bangladesh Institute of Sports, where sports is ongoing in different subjects and in relation to disability and others. Because there are some people are coming with disability to attending in the Olympic or somewhere else in the field of sports. And before I have done my work in the CRP, Center for the Rehabilitation of the Paralyzed, that is a huge organization in relation to disability. Whatever, I think in Bangladesh is a developing country, and there most of the people are not fully literate. So they have the lack of knowledge about the HIV. So through different ways, HIV can be produced in the human body, not only from the sexual purposes, but also lack of knowledge. For example, when anyone taking blood for his or her life saving, in that time they are not taking the sterilized syringe or something like that, or somewhere in Bangladesh, different clinics are not so much appropriate to transferring blood from one person to another person. So different ways HIV can be communicated towards the people. So physiotherapists are working in different places, and they are playing a great role to aware the people about the health sector and disability sector and the clinical sector. So in some cases, when patients are coming towards them, they can inform that some information about the HIV. And already I have heard that someone told that physiotherapy, all of you have explained very clearly that physiotherapy has a great role as one of the important member of the multidisciplinary team, but that was not included by the Ministry of Health. So physiotherapy should be included in the multidisciplinary team, and I think in Bangladesh physiotherapy can make a great role for awareness of this sector and for evaluation of this sort of patients and give suggestions towards them. And that will be a great innovation for this presentation. I think so.
Thank you, sir. Other innovations to share?
I don't know if I should call this an innovation, but the UNDP developed a program that they call Community Capacity Enhancement through Community Conversations. And I think that if every existing innovation and every existing HIV intervention program makes an extra effort to include people with disabilities in these community conversations, it's the one way of including people with disabilities in existing programs, because you then get to engage with them, to listen to them as to how they feel they should be included or mainstreamed in existing programs. So it's CCE-CC.
Thank you, Margaret.
I am Eugene Mutimura from Rwanda, and I think one of the most important innovations we should think about is the insurance coverage for people with HIV and AIDS who either have a risk or have some level of disability. I'm saying this because certainly you know that Sub-Saharan Africa is more vulnerable than the rest of the world in terms of HIV prevalence. And yet in some countries, insurance coverage is much higher than in other countries. I give an example of Rwanda, where insurance coverage is 96%. And communal insurance coverage is 91%. We call it mutuelle de santé. But there is a reluctance for some health insurance institutions to cover people with HIV/AIDS, especially if they have added disability or are at risk of some disability. And therefore, as professionals, we need to think of influencing policy by evidence.
Thank you. And while others are coming to the mic, let me add that Kelly O'Brien and I have conducted 2 Cochrane collaboration systematic reviews for more than a decade. on the role of aerobic exercise and the role of progressive resistive exercise among people living with HIV. And until recently, those were conducted exclusively in the north. A true innovator is Dr. Murimura, who is just addressing us, who has offered the first randomized controlled trial of exercise in southern Africa. So, sir, we've cited you extensively. It's very nice to meet you at last.
Yeah, my name is Gabriela Zokidi. I come from Kenya.
Hello, sir.
Yeah, the innovative we have recently with our government was to pressurize for somebody, especially a physiotherapist, to be in the panel of the Minister of Health, to head a section of TB and HIV as a section for physical medicine. And this could help us not only with the professional development in our care, but also with the allocation of resources all the way from the ministry to the community. So what we are doing now as professionals in our hospitals is actually trying to insist that within the interdisciplinary group, there is a physiotherapist in every team, in the PhD program, especially patient support care areas, where we see the people with HIV. We have a physiotherapist who always give a talk and giving the challenges that people with HIV experience, especially pertaining to physiotherapy. That is one. Then the other one that we are doing now in every health unit is that we have focus groups, and we have formed focus groups from especially people with disabilities suffering from HIV, their parents, and the people working within that community. So they can have a play, especially during HIV days, and sometimes education programs they take to the community areas, to schools and other maybe church groups. So that one is now taking place. We thought that was the best way. And these groups are used as the approach to the community. Yeah. Lastly, maybe it will be a bit late, but to Kelly. Yeah, you talked about the questionnaire. I was just thinking, trying to actualize it, but there's something I didn't know because it looks too ambitious for me. I don't know specifically what your intention was, what your vision was when you are going to analyze this data, because it might come out with a lot of information that sometimes I don't know how you go about it. Thank you.
Are you referring to the data on the HDQ? So first off, we're going to be looking at, first of all, describing the sample population. So I think this data that we've collected is going to give a good indication of the types of disability, symptoms, difficulties with day-to-day activities, uncertainty, as well as challenges to social inclusion. So a bit of a snapshot of the types of disability and the severity of that disability that people are living with. But we're also very interested in, this is also going to give also a snapshot of what aspects of disability are episodic and within a daily time frame. So in some of the earlier work that we've done, for example, as expected, things like symptoms and impairments like fatigue, pain, headaches, are more episodic than some aspects of challenges to social inclusion, such as work or personal relationships. So first of all, describing the sample and the types of disability people are living with. And then we're going to use this data to look at the measurement properties. So how reliable is this HDQ questionnaire? How consistent is it at measuring disability over time? And how valid is it? So is it really measuring what we want it to measure? Is it really measuring disability? And so these data will help us determine that.
Just to add a bit, I don't know whether you, in that analysis, you would think about age and the social background of the clients you are going to.
Very good question. So the age factor, absolutely. So alongside with the HDQ, we've been administering a demographic questionnaire to get a snapshot of people's personal and disease-related characteristics, such as age, antiretroviral use, the other types of health conditions individuals might be living with, and the time of their diagnosis as well. So we'll be able to take a look at whether disability differs based on age group, gender, antiretroviral use, and so forth.
And may I also just recognize what an innovator we have in Mr. Okiti. Sir, you're very humble. That was the introduction. Really, this is someone who single-handedly offers an outstanding rehabilitation program in rural Kenya. This is someone who has played host to many, many rehabilitation students from Canada, including physiotherapists. So we owe you a debt of gratitude for the education work you've done for the students in our country.
Good morning. I'm Karina Ekstein from University of Pretoria, not far from Johannesburg. And we're busy at the moment looking at a project where we use the endogenous pain inhibition for peripheral neuritis. So it's a small project. We've just began with it. And we would like to collaborate specifically then, would ask whether we could collaborate with you in Johannesburg, Kelly and Hellen. We've got a few ideas on how we would like to look at the influence of HIV on the rehabilitation then of our patients and their caregivers, because they disappear when they go into the community, and we find it very, very hard to follow them up.
Jennifer Jasper from the University of Cape Town, and I think you can see how much the South Africans are involved in these projects. So we have quite a few projects as well, one of which is very exciting to me. It's Jean Kajiso, whom the people from Rwanda will know. She started off by using the ICF and interviewing people who were on antiretrovirals coming for treatment. So she disappeared, and within a couple of months she came back with 583 cases with all the data about the HIV status. So we were able to really analyze that to see what impairments were related with what sort of activity limitations. Now she's taking that data and she's going to be running workshops in several hospitals to sensitize all of the medical people about the functional problems related to HIV, and then planning a referral pathway, and then looking at patient satisfaction. So she's wanting to use the ICF data to plan a very specific, and to get people to define what they will be able to use. So I'm very excited by having that online resource, because I can imagine the occupational therapists and the medical people up there would be able to access that as well, to get a better idea of their situation. Something else that we're doing is chronic pain, looking at chronic pain in HIV, and then doing sort of behavioral management of that chronic pain. So we're in the middle of an RCT looking at that. And then something that isn't anything to do with me, but I thought was really nice, is somebody, Meredith Harris from, I think, Northwest University. She's been in East London and doing a program on getting women together walking in the evenings. So she's got groups of people who are HIV positive, and they just get together, and every evening they go for a walk together. And this has actually become very popular and has taken off, very easy sort of social way of increasing activity levels. And then the last thing is, of course, looking at children and children's development. And we have a project going on now in Zimbabwe with Tekla and Bumble, looking at the older children, and this is why I was very interested about when the intervention started, because of course a lot of the children, say in Zimbabwe, if they survived, would have started treatment quite a lot later. And of course, because it's heterosexual, we have so many more children, and we don't really know what's happening to them at school. So she's now going to be looking at Zimbabwe, she's an occupational therapist, so she'll be able to look at the cognitive and the psychomotor aspects as well of their development, and trying again to do some sort of intervention at that level to see if it improves. Okay.
Thank you so much. We have a couple more innovations to offer. We're in our last few minutes, but we're so interested to hear what you have to say, so please go right ahead.
Yes, please. My name is David Tomusime from Rwanda. As I see on the innovation, I think as physiotherapists, we need to influence policy on monitoring disability, especially at primary health care settings. Take an example at like HIV clinics. Here, that's where we find most of the people living with HIV, and sometimes they start presenting some impairments that may lead to disability. But these impairments are not identified at an early stage for the prevention of the disability. And I think in most of the settings, for example, if we consider back like in Rwanda, you find at such a primary health care, you don't find any physiotherapists there. You find only nurses and some medical doctors, whereby they're just monitoring about ARVs and some other opportunistic infections, but no much concentration on such impairments that may lead to disability. And until when such impairments lead to physical disability and other disabilities, that's when a patient is likely to be referred to physios. And so I think we need such a monitoring disability at primary health care services. Such a policy, I think it's needed. Thank you.
Thank you.
Good morning. My name is Renelle Roos, and I'm from South Africa. I'm currently involved in a project with Hellen, and I'm so glad that David spoke about primary health care just a moment ago. We know that patients with HIV on ARV are at a higher risk for ischemic heart disease, and we're currently busy with a project screening patients at primary care level for risk factors of ischemic heart disease, and then hopefully in the future we'll do an intervention study to try and address these risk factors and limit disability in these patients. Thank you.
We'll give the last word to our friend at the back here.
Thank you. I'm Priscilla Ondoga from Uganda, and many physiotherapists in Uganda involved in HIV and AIDS care and in the training. Right now we're collecting data on children who are born to mothers who conceive while on highly active antiretroviral therapy. We've not yet published anything, but we're collecting that data to find out how the toxicity of the medicines affect the babies when they're born, how it affects their development. So maybe in the next 2 or 3 years we'll be able to have a report on that. Thank you.
Let me close this really enjoyable, at least from the front, symposium by saying that an innovation of our own that we'll commit to is moving forward with the idea of a special issue of an HIV journal focusing on HIV, disability, and rehabilitation. This is still at the idea phase, but it's something that after the discussion we've just heard, it's something that I'm sure that we can make move forward. So that's something else we will try to put into this report when it comes out to those of you who wish to receive it. I would like to thank very much my 4 esteemed collaborators, all of you who have tolerated our innovations in terms of format this morning and participated and played along, and especially those of you who stepped up to the mic to offer the innovations that you have. This is an exciting area, and we're glad to be in it with you. Have a great rest of your day.